So if Thank you, Amy. If you guys have questions, you guys can drop it in the chat or you can wait till the end. And so first I'm just going to cover the agenda right now. Hang on. There we go. So our partner spotlight today is going to be Care Partners. So we have Jordan who's going to be doing that. Then we have some updates from our resource team on our GetHelpOC website. And then we also have some updates from our um, resource Get Help OC team on the Get Help OC side of the house. So we have a lot of information that we're going to be able to go through. But thank you guys all for attending and making time for this. It's good to see everybody's faces. And so I'm going to turn it over to Jordan from Care Partners. And Jordan, when you want me to go to the next slide, you just let me know.
Cool. Well, awesome. Thank you so much for giving us the opportunity. Your partner spotlight is Care Partners. Makes it easier. But thank you so much for the opportunity today. It's good to see some familiar faces amongst the folks here as well. And so I think we're a relatively new partner in the 211 network and with Orange County United Way. I want to talk a little bit about the ways in which we're helping our high-risk managed Medi-Cal members within the community in hopes that it gives some resources for folks who may have individual patients or clients, that could benefit from these services. So Care Partners, just so you guys know who we are, we're based in Irvine. We were founded in 2016. Started mainly as a private pay home care provider, but over the course of the past, oh my God, 9 years, we've really become a resource for much more than that. And so what we'll talk about today predominantly is the resources that provide for individual managed Medi-Cal members from a personal care, homemaker, and respite service providing model, as well as enhanced care management, which is, as we'll talk a little more about, longitudinal ambulatory in-home case management. A lot of words. But we started in 2016. Our goal is to attack everything and approach everything with love, compassion, and empathy. Our founders, two of them, one is a lifelong healthcare, I would say executive, I guess isn't even right the word. He's an executive now, but he started as a dishwasher at Los Alamitos Medical Center when he was 16 years old, and then slowly worked his way up through the hospital systems itself. And now he's owned a handful of companies, Randy Platt. And then our other founder is a gentleman, Roddy Burris, whose story makes him unique because of his lived experience. He's been a patient for about the last 25 years. He's had a whole number of health issues, and they founded this company on the concept of the magic that happens when individuals who are in the health system are really listening, pay attention, and approach things with love, compassion, and empathy. Those are two of my leaders. I have lived experience myself in the sense for these types of home care models. I got into home care about 12 years ago, but my experience with it was 13 years ago. My grandmother, who was 86 at the time, had a real bad bout of pneumonia and had a UTI to boot. And so someone who was completely self-sufficient one day was incoherent and unable to fend for herself the next. And my dad and I had to attack the home care space in Florida in a different state and without any resources, and we didn't really know what we were doing. It wasn't a great experience. And so about a year later, a couple of friends of mine had started a company called 123 Home Care based in LA, and they needed someone to help grow their operations and their sales. And I dove in headfirst, knowing that their goal was to try and make those types of experiences for people like me a lot easier. And so we did that there, and we've carried that over to our time at Care Partners. And so we'll talk a little bit about the models here, but hopefully for those of you that have patients that are navigating similar types of scenarios, this is a good resource for them to be able to find a way to wrap themselves around with services that can help them stay safe and cared for in a home. So in my past life, I was a lawyer, so if I talk too much, that's usually the case. So, just use your hand motions and you can't really play me off. So just use your hand motions if I'm not shutting up. But feel free to also, I have the chat open as well. So if there's any questions that come by, much more fun if I'm answering questions versus just talking at y'all. So I know that's hard, but feel free to throw them in there. So you can go to the next slide. So what I'm going to start just with something that's probably very familiar with y'all, is CalAIM. The services that I'll talk today about are predominantly covered by the CalAIM program, but for those of you that are unfamiliar, CalAIM, it's an acronym, stands for California Advancing and Innovating Medi-Cal. It was an initiative that was launched in January 2022 with the goal of transforming care and care delivery and care education for our high-risk managed Medi-Cal patients throughout the state of California. Obviously, in Orange County, the largest provider of these services is CalOptima and its supporting networks, but Kaiser also has services that render here. So for any individual patients, clients that you have that have managed Medi-Cal, I will do that, Lisa, sure thing. Anyone who has managed Medi-Cal in the state, not just Orange County, through one of the providing managed Medi-Cal networks, these programs are there to support managed Medi-Cal members. So the program in itself is built up, it's made of 15 separate programs. The capstone is ECM, Enhanced Care Management, and that is something that we'll talk a little bit more in depth, but that's essentially, as I said, a high-touch longitudinal in-home case management and social work model meant to provide individuals who have health literacy issues, health education issues, and who are just having trouble navigating the health system. How do we wrap supports around them in an effort to ensure that they can maintain their quality of life in home and have better baseline quality of health. So it's enhanced care management, and then there's 14 other community supports. Some of you may know some of these community supports in the past. Many of them were known as in lieu of services, but in 2022, after about a 10-year study, they aggregated the most impactful in lieu of services and packaged them into what they call community supports as part of the CalAIM program. So can go to the next slide. All right, so I'm not going to go through all these. I highlighted the ones that we provide. That's in addition to ECM. But for those of you looking for resources for high-risk Medi-Cal patients, here's 14 of them. And so there are a number of pre-approved community supports for any managed Medi-Cal members in Orange County. I'm sure a handful of the folks on this call actually provide these services. So thank you for what you do. But here's 14 of them. Again, it runs the gamut, things from asthma remediation, which I didn't even know was something that was available, all the way down to what we do in personal care, homemaker services, respite services, recuperative care, housing assistance, housing deposits. I mean, some of these things that I just didn't even know were available for a lot of our members and constituents here in Orange County. So really, really cool programs are available through CalOptima and Kaiser here in Orange County and through the other plans throughout the state. So I won't spend too much time on it. What I am going to spend time on are the respite services, the personal care, and the ECM. So we can go to the next one. All right. So for those of you who don't know what home care is, I apologize. This will not be a run through on that, but it is fairly straightforward. We're looking at individuals who need help with what are called ADLs, activities of daily living, or IADLs, instrumental activities of daily living. So things like personal care, getting dressed, getting up and down, fall prevention, ambulation assistance, their morning routines, all that kind of stuff. And then the IADLs are things like, chore assistance and meal prep and all that kind of stuff. And so essentially these are folks who are living in the home, but need the help of an extra set of arms, legs, eyes, ears, to be able to remain and do so safely. And so there's the first of the two programs that provide these services is what's called the personal care homemaker benefit. The second is respite. So I'll go through each in kind, but just very simply the high level bullet points. Personal care services, these are for folks, it can provide through CalOptima or Kaiser, you can have anywhere from 2 to 6 months of care in the home from a licensed organization like ourselves or the handful of others that are located in Orange County. And you can have up to 45 hours a week. It's a pretty substantial amount of home care, and it's meant essentially to bridge the gap for those that would be IHSS appropriate and are either just starting the process to get IHSS or have received IHSS and can't get a caregiver yet. Orange County does a lot of things well. IHSS tends to be something that's a little bit slower in its implementation as compared to some other counties. And so CalOptima and Kaiser and the other organizations realized there needs to be a resource for folks that need it sooner than 2 to 4 or 5 months. And so they came up with this CalAIM personal care services model. So we'll talk a little bit about the eligibility there, but essentially you're looking at folks that can qualify for up to 45 hours a week of care for a 2 to 6 month window. There are some ways to extend that, but while they're waiting for or applying for IHSS. The other program has no attachment to IHSS, and it's essentially a respite program. So CalOptima and Kaiser both offer 336 hours a year for individual who has a primary caregiver. That can be a spouse, can be a daughter, can be a family member, can be a neighbor. But if you have a caregiver, paid or unpaid, and that person needs a break, regardless of their IHSS status, most managed Medi-Cal members will be eligible for this 336 hours a year. 336 seems like a random number. It's actually not. It's meant to encapsulate essentially 2 weeks of 24/7 type of scenario. And so folks that maybe the caregiver needs to go out of state or out of country, and they need extended care for, a shortish period of time, but longer than a day or two. That's where the 336 came into play. But a lot of folks, most folks for that matter, use it, 4 weeks, 4 hours here, 6 hours there, or whatever it might be, to, as it's meant to be, a respite for their primary caregiver. And so essentially it's there to create a break for the primary caregiver. So you can go to the next slide. So a little bit more on the eligibility for a personal care homemaker. So as I mentioned, there needs to be, for this larger program, there needs to be an attachment with IHSS. And an attachment can either be, as I said, they've been approved for IHSS and they need more hours, meaning there's been a change in condition and they need more hours, or they've submitted an application for IHSS and it's still pending. And so those are the two instances. For these larger scale hours, there needs to be an attachment with IHSS. That's kind of the most important thing to think about when you have these types of programs. If they don't have IHSS or they don't qualify for IHSS, there are a couple of options for them, but typically they're going to be able to maintain this benefit free of charge if they have an attachment with IHSS, like the ones that are listed here, and that essentially they're at risk for hospitalization or institutionalization in a nursing facility, have functional deficit, no reliable support system. Essentially, they need support with one or more ADLs, and they can't currently be residing in a SNF or an ALF, so no RCFE or a place that has essentially 24/7 nursing care. So these are folks that want to stay home, but without the use of caregiving, likely would not be able to in the long term. The bottom, you see hourly allotments, anywhere from 11.75 hours to 45 hours based on need. And so, for folks that already have IHSS in place and are receiving those services, they're typically going to be on the lower end of that because it's meant to be an add-on. And then for folks who are pending IHSS and have had no allocation at this point, they can receive again up to 45.25 hours a week, which is really substantial for folks that need the care. The authorization length anywhere from 2 to 6 months. Kaiser has been a little stingier. They're starting with 2 months. Then you can get extension, usually in 1 month increments based on where they are in the process of the IHSS. Cal Optima has been really lenient on the front end, and they offer a 6-month preliminary auth, and then they do usually 1 3-month extension if there's an opportunity or reason for them to do that. And go to the next slide. And a little bit more on the respite side. Again, this is no IHSS attachment. Member has and is dependent on a primary caregiver, can be family or agency. They're predominantly homebound, and without that caregiver, they need to be in a facility. Essentially this is a person that helps them with the vast majority of their ADLs, IDLs. If they weren't there, they'd have to be either at a SNF in short term or short term in ALF or whatever it might be. They can't reside at home safely for extended periods of time without support. And so again, max of 336 hours a year. And it's meant to provide respite for that primary caregiver. They've been really lenient with that too. Unless someone receives respite benefits through maybe the regional center or some other DHS type of program, they've been really good on approving all 336 hours of that. Cool. On to the next. All right. So a little bit about the operations here. So those are the two programs, and you can feel free to either raise your hand, or I can't see everybody's face, so chime in if you have a question. But I'm going to stop at the end of the home care stuff too briefly. But one thing that's a little bit unique about how we operate the program, we're a licensed full service home care organization. So all of our caregivers have to be employees. They have to be screened by the state, fingerprinted, live scan. They go through our training orientation. They get a physical, all those types of things. So we have about 1,000 caregivers on our employee roster. At any given time, maybe about 500 or so are working. So we do have a fair amount of bandwidth. But what we found is that for individuals that are in the community and maybe there's a language barrier, maybe there's a cultural barrier or cultural concern, oftentimes the best way to get continuous care is to have somebody that they trust already to be their caregiver. And so for a lot of our high-risk members, again, especially with languages or cultural, they don't want our agency to come in and provide a caregiver, even if they might be a great fit. But there's that time. This is a person-to-person relationship. It's obviously difficult to foster that, and you're talking about things that are, really personal. So what we try and do, especially with these programs, the Calian programs, is when we're doing our intake, if there's a family member, a church member, a community member, anyone that they trust, to be their caregiver, we will screen them, hire them, train them. They obviously have to get through our screening process, so they have to be able to pass a background check. They have to be able to get through orientation. But essentially, this has created a much higher, I guess, throughput, and not to sound like a total business nerd, but we've had much more conversion of families that are maybe hesitant to come on our service because now they have a caregiver that they trust. And our orientation process takes a couple of weeks, so it may be a little bit longer to get somebody in place. But after a week or two, they're screened, they're trained, and we're making sure that they have the tools necessary to be able to provide care in the home, and they're getting paid for it. A lot of these folks would do it without getting paid for it. So all of a sudden, you're finding a way to kind of create both a revenue stream for folks and some pay, but also fill a much needed gap in the caregiving need for that family. And so that's been a pretty successful program for us, especially with our Calian clients, because we do work in a lot of areas where there's where there are unique languages or things like that, where they just want someone that they know already in to be in their house. That said, we do have lots of individuals that speak varying languages amongst the 1,000 caregivers, so we've been able to do that too. But it is definitely an option. So I see that the question is, caregiver required to provide proof of permission to work in U.S.? Absolutely. So every caregiver has to, provide their appropriate documentation and their I-9, fill out an I-9. That's something that's required of all licensed agencies that provide home care in California. So yes to that question. Could move to the next one. Okay, cool. So I'll pause there for one more. Oh, we got Elsa just in a minute too. Because we're about to go to ECM. So we'll pause here and I'll take any questions on the home care side. So what kind of training? So we have in-person orientation. It encapsulates about 20 hours. It goes through best practices with transferring, best practices with Alzheimer's and dementia care. So how to redirect, obviously basics in, the not so fun stuff like diapering and searching for bed sores and, and all that kind of thing, safe transfers, I mentioned, fall prevention. And then it goes through a bunch of disease specific training for, as I mentioned, Alzheimer's, dementia, Parkinson's, and a plethora of other things. We also go through, obviously, our operations in itself and the different members. We work a lot with the regional centers too. So, we talk through a lot of autism strategies when it comes to how to navigate those types of situations and work with individuals who may be violent. So it's a lot. I'm happy to share kind of a little bit longer list of things, but it's a pretty in-depth that includes both hands-on, so transfer systems and that kind of stuff, and then a lot of classroom. We use a company called Home Care University, and we run through a lot of their best practices models and education models to ensure that individuals kind of, when they walk into the home, they know what to look for and they know how to help folks. So it's a mix of both classroom and hands-on stuff. Any other questions on the home care side? This is just real high level stuff too. So if there's anything, I'll put my email and stuff in the chat too. I think just one thing question I typically get is, how long does it take to get in place? The referral process is fairly simple, but it takes about 2 weeks. So once somebody sends in a referral to us, we'll check their eligibility. And if they're eligible, which is typical, and I guess I'll talk through the exclusions. But we submit the authorization to Cal Optum or Kaiser, and we get an answer back usually within about a week to 2 weeks. It's good to know for clients that are utilizing this, Kaiser and or Cal Optum will call and do a similar type of assessment. It's not in person, but they'll do over the phone. Hey, they'll ask, it's 14 questions about their needs and what kind of assistance they need in the home. So, it's good to let your folks know, whether it's the client contact or the client themselves, that that so-and-so after this comes will be reaching out to help them through this process too. But then the health plan will be reaching out to do some confirmation of the needs in the care plan. It takes about 2 weeks. On the home care side, the only individuals that don't qualify I mentioned the IHSS, so that's one thing, but they can't have a share of costs. And that's, I know, frustrating for some. It's frustrating for me. But the hard part about that is that, as many of you know, if someone has a share of costs, they could have Medi-Cal 1 month, and then not have it the next month if they don't meet their share of costs. And so what we ran into, unfortunately, was that we'd providing services a handful of times where we couldn't get reimbursed. And so we had to make the decision that if there is a share of costs involved, that we can't, unfortunately, enroll that patient. But beyond that, as I said, the eligibility is fairly straightforward, and the programs are meant to be inclusive. They're meant to be able to get access to these resources. Any other questions on that before we move on? Cool. All right. So ECM is the other end of this. Enhanced care management, it's my baby. I love it. We've been running it for about a year and a half. As it says here, fairly simply, it's an ongoing in-home case management for managed Medi-Cal members with one or more social determinants of health factors affecting their health and their kind of the health system utilization. So these are folks that, again, either they maybe there's some form of a barrier, whether it be economic, whether it be intellectual, whether it be educational, whatever it might be, language barrier, but they're having trouble navigating the system. And so this is a longitudinal program that has an authorization of at least 6 months. But most of our patients stay on for more than that, where we're going into their home and we're providing case management, social work in person, and then in between visits, case management assistance, closed loop referrals to specialists, primary care, whatever it is that they need in their home. And so these are, again, high risk managed Medi-Cal members who really need that extra support. Many of them are non-compliant, whether there's a fear or a lack of understanding. These are folks that are utilizing the ED for primary care, or they have a primary care that's set up in through Medi-Cal, but they've never met them, or they're not in the same town, or they can't get there. I mean, there's so many different things that get in the way of individuals being able to receive appropriate healthcare, even if they have the coverage. And so our job is to reconnect these individuals with the appropriate resources so that they can live a healthy life. And then make sure that they stick to it. And so that's the longitudinal nature of it. As I said, 6 months is usually our minimum LOS, but this program is meant to be ongoing until and unless we meet their care goals, and we can titrate them down to a lower level of care, whether that be an MSSP program or PACE or something along that nature. And so, as I said, we have an assigned lead case manager, an LCM, who visits the member monthly, and they're facilitating those connections. Primary care specialists, mental behavioral health, medically tailored meals is a huge thing. Meal delivery, transportation, as I mentioned earlier, transitional housing. So folks that may be having housing insecurity. Our population of focus is not specifically the homeless, or the unhoused, but we do work with a lot of folks who are on that fringe. And there are other organizations that focus predominantly on homeless population, that organizations like Illumination Foundation and others. But in those instances, we can certainly help. But our primary is for folks that are maybe having short-term housing insecurity, and then we help link them with additional resources, rent support, home modification, whatever it might be. Placement's also part of it. Adult daycare, helping them with that, emergency response systems and DME, making sure that home health and post-acute visits and all that stuff is set up appropriately. And then, of course, because we have the caregiving side of it, of course, that's part of it, but other social services resources, hospice if it's necessary, palliative care, all those types of things are part of what our LCMs are out there connecting these individuals to create a better baseline of health and to give them the ability to navigate our health system in a way that's more conducive to their individual needs. So you can go to the next slide. So who is eligible? This is the kind of important stuff. So individuals with 3 or more unplanned inpatient admissions in the last 6 months. So the folks so affectionately referred to, not my favorite phrase, but you got your frequent flyers. I like to call it individuals who are cyclical utilization or high utilization, but folks that are going back and forth. And then again, individuals with 5 or more ED visits. Those folks typically are falling into the category of folks that are using ED for their primary care. And obviously that's not an efficient utilization of resources. And so if we can find a way to get with these folks before they need to get to the ED and create a better baseline of health, that's, again, definitely part of our population focus. So folks are going back and forth to the hospitals. That's a big one for us. And then this third bullet point here, this is a very broad category, meaning it's meant to be a catch-all. This is very simply adults living in the communities, meaning they currently live at home, but they're at risk for custodial placement in a long-term facility. So this is somebody who, for whether it be a change in condition, or through the aging process, natural process, whatever it might be, they're at risk for having to go live custodial at a SNF or board care, whatever it might be, because they don't have the right resources. But if they had the right resources, they'd be able to remain at home. And so that's a very broad category, and it's meant to be that way. ECM has been a huge, I guess, priority for the health plans and for the state, so much so that it's funded not just by the health plans themselves, but also by the state. And so they're trying to capture as many folks as they can and enroll them in these programs because it has shown itself to create lower overall health costs and better health outcomes. The last one, a little more niche, but individuals who are currently custodial in a SNF and who are wanting and able to live in the community if with wraparound supports. And so that's essentially that the individual who's the one up, who could have been living in the community but couldn't do it. Well, now, folks, if there's just a handful of community resources that would allow them to live in the community with and not in the SNF, and they have a place to go do that, then that's obviously what our team's going to try and do. And that's, again, to eliminate SNF utilization where unnecessary and to create a better quality of life. There's some SNFs that are great by all means, and I think we all know there's some places that aren't as happy of an existence. So if we can get folks in the place where they want to age and they can do it safely, that's the goal. Exclusions, just as the end there, if you want to just go back to the last one, patients with share cost, as I mentioned earlier, patients with who are D-SNP or on one care plans, and that's their duals. That's because many of the Medicare plans may already have a similar program like ECM, even if it's complex case management, they may have that in-house. And so they're considered duplicative if they're on ECM and simultaneously a D-SNP or one care complex care plan or complex case management plan. So we can't accept those individuals either at this time. We're looking at how we can become the CICM complex integrated case management provider for many of the managed Medi-Cal plans. But that's a whole entire separate process. It's probably not going to be live for us until 2026 at the earliest. The last exclusion is, again, of course, hospice. Well, they can be on our services until and unless they go on hospice. Once they're on hospice, it takes over the vast majority of their medical care, and obviously the hospice company would take over as their primary from that instance. So 3 main exclusions there that are notable. You can go to the next slide. All right. So this section, that's when I probably should have pulled this slide. But if there are individuals on this call who are working in acute scenarios or post-acute scenarios, the early identification is really meaningful. I had here time to educate bedside. If there's folks that we can talk to, maybe it's an individual of your clients that's going into a SNF or just went into a hospital. Sending over referrals early is really important because we can get and educate these folks before they go back home. With an opportunity to then provide these resources and have them ready for them once they come back to their home. Obviously, coordination with community health workers and individuals in the ED is really, really important because that's where we get a lot of our referrals for folks before they're acute, and the kind of the aspect of it. They don't need to be in an acute healthcare system to receive these services. The best and most successful ones we have are folks that are just struggling right now, and if we can get it before they go acute, then there will be no need for them ideally to end up in a hospital. Last thing, I guess, a lot of folks, they say, oh, I'm not really sure on the eligibility, I'm not going to send it. That's one of those things that if there's a question, feel free to just send it over and we'll take a look at it and we'll let you know if they're going to be eligible or not. And that's one of the things that's differentiated from other ECM providers. There are plenty of them out there. But our goal of being a real true closed loop referral source where we can connect with the individual that sends the referral in, let you know it's received, let them know that we've submitted the authorization, and so on and so forth. That's all of us on this call. I hope in some way, shape, or form care about the individuals that we're serving. And I know one of the more difficult things for our hospital partners is once they leave the 4 walls, they don't know what's going on with these folks. And this is an opportunity for us to kind of, hey, here's what happened, here's where we're going with it, and if we're not the right referral source, we'll send it along to somebody who is. But the goal is, how do we increase the communication and make sure that y'all know what's happening with these individuals, because you have a stake in it, and many of the times it will be co-patients or co-clients at the same time. You can go to the next slide. All right, so these are our contracted health plans. This is, you'll see in Orange County for home care, We have all of them, and we have every single health plan in Southern California except for right now Community Health Group CHD for the home care side. I'm working on that myself. It's been tough. They have a closed network right now, but we're hoping to get through to that. So on the home care side for the personal care services and respite, that's something that's available to them. And then on the ECM side, HealthNet, Molina, Anthem, CalOptima. Kaiser will be coming the next month or two here. We have a contract that's just waiting on co-signature from them. But so CalOptima will probably be the biggest one you see in Orange County. But Kaiser will be with us likely in the next month. So we'll be able to take Kaiser members on the enhanced care management as well. But yeah, so those are the two differentiators. I wish I had everything for both. We unfortunately don't. But CalOptima, obviously the biggest player here in Orange County, could be impactful for you all on the ECM side and definitely on the home care side. I think that is it. Yeah. So last but not least, of course, how do you get stuff to us? You can always call us, you can fax us, you can email us, you can scan this QR code. I know, I'm assuming Blessed and the team will be sending these out, the slides out. So there's a QR code there too. I'm gonna put my name and email and phone number in the chat.
Yes, please.
And sorry, someone just waved at me. 664 here.
Okay, yeah. Thank you so much for the great.
So that's it. So it's in there. If any questions or anything, feel free, just let me know if you have. I'm always happy to provide more info and you know, again, rising tides raise all ships. So however we can help create better health outcomes for everybody, and we're always happy to do it.
Yeah, thank you. That was a great presentation. A lot of information there. So we are now going, if you haven't already dropped your name into the chat, please drop your name and your organization into the chat. And we are going to turn it over to Elsa from our resource team. So Elsa, it's all yours.
Hi, everyone. I'm Elsa, and I'm part of the resource team. We're the ones that email you once a year, trying to get those updates from you guys. So in case you do have an update before we reach you every year, we want to make sure that we capture that information from you. So I'm just going to go through a little, just a few steps on how to do that so you guys know how to reach us and to update your existing services. So it's very simple. You can fill out a service update form at this email address. I mean, not email address, website address here, which I will show you where to go in after these 2 slides. So when filling out the form, you want to include your agency's full name and the full name of the service you are updating. This is really important because some of the agencies do provide some same services in other areas of Orange County, and you may have the same name. So we just want to make sure we have the agency name and the program that we are updating. For fields that that are going to remain the same, you can put same as listed now, so you don't have to go through it and say, oh, this is the same, and you have to type it all out. And that'll all make sense once I show you in a little demo right now. So what we do want from you is to enter all new and updated information. That's what we'll look at, and that's what we will update. And then at the end, you can go ahead and submit the form. And then our resource team will follow up with you to confirm all updates. So once we have updated, we send you a public service link, and that'll you'll go over that information, and once you okay it, and we'll make it live. Next page. So this is just to get your if you have a new service, it's the same thing. You go to the same service form, a website there, and you must include the agency's full name and the name of the service program. Provide all necessary program details so we can build it out. If any information matches any existing programs, you may enter it as same as program in something that's already in our database. So it's not redundant and you're typing things over again. You'll submit the form again, and our research team will once again contact you to verify the submission. So it's very straightforward, very simple. But if you have any questions regarding how to submit the form, or say something that in the form isn't capturing what you want us to update, go ahead and you can email us at resource@unitedwayoc.org. And then, Belisa, if I can share my screen so I can show them where to go.
You should be able just to hit share, because I think He has it. We can share.
Perfect. Can everyone see my screen?
Mhm.
Okay. Wait, let me see.
Whoever's not muted, so
Okay, so you go to 211oc.org here, you'll come up with our homepage here, and then you'll under for network partners, the first line here, helpline database. You go, it'll give you another drop-down menu, and you can go ahead and click on service form. And this is the service information form. You'll want to type in your agency, legal name of the agency. You can either click yes, obviously, because you are part of the GetHelpOC program, and your service name. This has to be the full name. If there's any other names that goes by, you can enter it here. You can enter your description. Here you can say same as before. The same here. You have to, for this one, you do have to enter all of it, or else it won't go through. The same thing with mailing address, same as above. Referral phone number. You do have to type in a phone number for this area, or else it won't take it. So I can't even, it won't let me type any actual letters. And the same thing with the website. Make sure you type in the website correctly. It won't let me just say same as listed. It won't let me. So just make sure to do that. Service hours, it will let me say same as listed. The same thing here. Same as listed. Eligibility, same as listed. So this is just, will make it a little easier. So you don't have to rewrite everything, because I know it can be a little nuance of rewriting everything. But you can click on if anything has changed with languages, services provided, or payment fees, go ahead and select those. Fee information, if it's same as listed, go ahead and say same as listed. Any edits on the application process, go ahead and click on that. Gender served, area served, specific locations. We do want to capture whoever is updating this. So if we have any questions, we can call you or email you. So make sure to fill that out, and then your phone number and email. And then once you put in we make sure that you're not a robot, and then send inquiry. You can click send inquiry here. That's pretty straightforward. There's nothing to the form really. Just enter your information, and if it's something that's already listed, just say same as listed. Does anybody have any questions or regarding this? No. Okay, great. All right, so next slide.
stop your share.
Oh, did I not stop share?
There we go.
Okay. All right. So we do partner up with utilities such as SoCalGas, and we just want to make sure that all our community and agencies know of all these programs that SoCalGas participates in to help the community. So I'm going to talk about a little bit about what SoCalGas has to offer. The first one is the CARE, the 20 monthly discount. So folks that usually that can qualify, a lot of them may have Medi-Cal, do qualify for a 20 monthly discount on each bill every month. They do have to they do have to qualify and apply with SoCalGas, but that is available for them. They also have a medical baseline allowance program. So this allows, if there's anybody in the home that has a medical condition that needs more heat, they can apply for a lower rate for gas. And there's no so there's no, they don't look at income. Anyone can apply as long as there is a medical need for it. There's also something a rearrange management plan. That's a tricky one to say, but it's a past due bill forgiveness. If there is a client that has past due balance, they can qualify and they can apply and see if they qualify to get some of that forgiven. But the key here is that they do start paying their bill, and then any past due bills do start getting forgiven. There is also something, the Gas Assistance Fund, which is a one-time bill grant. SoCal Gas works with other agencies to give this fund out to, it's a one-time fund to clients who qualify. By calling 211, the client will be, the INR information and referral specialist can let them know which agencies can help them with that grant. And that's pretty much it. That's it. Any questions?
No, thank you so much. Again, if you're not muted, will you please mute yourself? And we're going to keep going quickly on to Diana because we have a lot of additional information. So Diana, it is, wait. Nope, there you go. All yours.
Hi, everyone. So today I'll be reviewing a few different GetHelpOC topics. A few of them are going to be refreshers and the rest are going to be new updates. So starting off with agency minimum participation requirements, just a quick refresher on some of these requirements. To participate within GetHelpOC, all of our agency partners have to adhere to the GetHelpOC participation requirements. One of the agency minimum participation requirements is to respond to all direct referrals that your agency has received. So referral managers are responsible for responding to the initial referrals in a timely manner, and best practices are to respond to an initial referral immediately or within 2 days, but no longer than 14 days. So another participation requirement that I'd like to review is for any personnel changes. So in certain situations, a staff is no longer working there, so all referral managers must notify the GetHelpOC help desk for all of these personnel changes. So like I mentioned, when a GetHelpOC user no longer needs access to GetHelpOC, whether due to changing their job responsibilities or departure from the agency, referral managers must update the GetHelpOC team immediately, but no less than 2 business days by submitting an account update form. And then once the form is received, we'll work on deactivating the user. Next slide, please. Okay, thank you. So for referral outcomes, for our GetHelpOC partners that receive direct referrals, all referrals should have a recorded outcome in a timely manner. When recording an outcome for a referral, select the outcome that is appropriate. The recording of an outcome should be recorded once the client has a definitive resolution to the referral. For guidance on how to select the appropriate referral, review the table that is located within the article, navigate the referral tab, and log in an outcome of a direct referral. On the right side, you can also see an example of that table that is located within that article. And so you can view this table to gather some guidance on how to select the appropriate outcome based off of how the referral was handled with the caller, or with the client, I should say. Okay, next slide, please. So continuing with referral outcomes, right now our referral decision helper pick list will be updated. So this is where you record that outcome with the client. So before changes are made, we do invite our partners to share suggestions for any additional outcome options to be added. So as of right now, the did not receive services is currently listed, but it will be removed. So now the reason client did not receive the reason client did not receive services will be included in the main pick list. So client refused, client did not show up or call. Other options are available in the pick list already, and service is not accepting new clients, which equals no capacity. So in the chat, we are sending out a survey that will be included along with the PowerPoint, but it's also in the chat. And this is just so you can provide any suggestions as to any new referral outcomes that might be helpful for your agency or that we don't currently have listed. So as of right now, I'm going to pause just to see if anyone has any questions so far on any of the topics that I reviewed.
I don't see anything in the chat.
Okay, awesome. Okay, can you go to the next slide, please?
Yepers.
Okay, thank you. So this is for user account updates. So in certain situations, a referral manager is sometimes out of the office. And so we do have a procedure in place where you can assign temporarily a referral manager. And so they are going to be listed as the interim referral manager in place while the main referral manager is out of the office. So to complete this request, the referral manager must submit an account update form, which can be located on the GetHelpOC website. And on the form, you must enter first the information of the referral manager making the request. And then under GetHelpOC User 1, that's where you can enter the details of the temporary referral manager. Under this GetHelpOC user is, there will be an option where you can select transfer to interim referral manager role to primary referral manager being out of office. So this basically just means that you're assigning a temporary referral manager in place. And this will give the user the temporary referral manager role where they can continue accepting, denying, or assigning the referrals to the case managers. And then once your return date has arrived, we'll go ahead and assign the roles back to the designated referral manager. Okay. And then the following questions I will populate will ask if you would like all active and pending referrals to be transferred over to the interim referral manager, and select the response that is appropriate to your agency needs. And then that's where you can enter the date that you'll be out of office and then the date of return. Okay, next slide, please. Okay, revocation of consent. If a client wishes to revoke their consent, they have two different options. First option, if a client would like to revoke their consent, they can obtain the GetHelpOC client revocation of consent form on the GetHelpOC website. And you can download this form and then email the GetHelpOC@unitedwayoc.org email. The second option is that the agency or staff working with the client may also upload the form into the client's profile and email GetHelpOC@unitedwayoc.org to request support with anonymizing the client's profile. If the client revokes the consent later, it will not affect information that has already been shared. Okay, can you go to the next slide, please? Okay, so now for the updates, there are a few changes on the GetHelpOC website, and we have added a few modifications. So under the Community Partners tab, there will be an update regarding adding a flowchart. Right now, it's currently not added, but before our next meeting, it should be listed on the website. And then under Training and Meeting, there should also be the accessibility of also viewing all the training courses as well. And you can see all past provider meeting materials. So let me just do we still have time for a quick demo so I can? Yes, okay. So let me share the screen really quick so I can show you where these updates will be. Okay, can you see my screen? Okay. So this is the GetHelpOC website, and under Community Partners, there will be an option where it says the GetHelpOC flowchart. So once it's available, you can see kind of an understanding of who to reach out to if you don't know who works on what. Like for example, I work under the help desk, so any functionality questions, you can reach out to me. So that's just an example. And then under training and meetings, it's currently live. So you can have easy access to the GetHelpOC training courses, and then you can see all previous provider meetings. So this is the one from April. And then let me just show you quickly here for the training. And then you can see all the training courses under here. Okay. And I believe those are all my updates for GetHelpOC. If you have any questions, you can submit a ticket, and then I can also provide you a response back through there.
Thank you, Diana. And I do want to say, like, reiterate what she said, like the easiest way for those of you when you're having issues with like either like our website, and we do know that sometimes like the email that says you got a referral has not been working for some people, and we are working on that. But also when you have a question or if something is not working, either it's your login or if you have an issue, the easiest way to get and the fastest way of getting help is to go to our GetHelpOC website and put in a ticket for that. That is the way our team is going to be able to respond the quickest, instead of like emailing me, because usually what all I'm going to do is I'm going to send it over to Diana anyway, or tell you guys to create a ticket. So if you guys, everyone can get in the habit of going into our GetHelpOC page and going to where you need to put in a ticket there for assistance, that is going to be your quickest way of being able to get help faster. And if you guys could please make sure that any of your case managers or referral managers, anyone else who is part of our platform that's not here today, if you can please pass it on to them to know to go to our website for, getting connected to services, that would be fantastic. So thank you. And I want to say our top agencies with successful connections this last quarter are the Delhi Center, Korean Community Services, El Sol Academy, His OC, and the Thomas House Family Shelters. So thank you all so much. It is incredible to see how much this is growing. And we're super proud of all of our partners. And speaking of that, we've had this last semester, they're not all on here. So I don't know wait, hang on. They're not on here. I don't know why. If you would have seen in our partner newsletter, there should be a slide on here that recognized all of our partners. So it was in the newsletter, but we ended up having 24 new partners that came in from January through April. And so we're really excited to have all of them on. I'm going to make sure that I send it out to all of you. It was in the newsletter. So if you guys didn't get the newsletter, it's also on our GetHelpOC website, but it listed all of the 24 partners, and I'm not sure where the slide went. That's my fault. That listed all of them in there, but we're super happy to have the 24 new partners. As you know, our goal is to continue to be adding as many partners as we possibly can. This last year, we had the goal of reaching 100 partners by the end of the fiscal year, which we ended up at 101. So we were really excited that we met that goal. We were hoping to add on additional 85 to 100 this next fiscal year. So we are going to be doing things a little bit differently. Like in August, we're going to be doing a big giant GetHelpOC demo like all of you guys received when you first came on and you had an individual demo. We're going to be doing a big one on August 20th. We'll make sure we send out the link for everybody. So if you know of any other organizations that you think would make a great network partner for us, we would love for you guys to be able to share that with them and say, here's the date. They're going to be doing a demo. Just go watch it. There's going to be no pressure. There's going to be no push. There's going to be no hard sell on it. We just really want to be able to try and reach as many people as we can. It's going to be at 11 o'clock, same time as this meeting. We'll be using the same link. So I will be sending that out to all of you to make sure that you guys can share it with any other agencies, because we do want to bring on as many as we can, because we're only as good as the agencies that we can refer to. And if we are seeing anything now more than ever, this is the time that we need to come together and wrap our arms around this community and help support them as best as we can. And so we're really hoping to be able to do that by bringing on more network partners so that we can make those connections to the correct services. So look for that and please share. Our next network meeting is going to be in October, which seems so far away, but it'll be here before we know it. There is the link that is going to be the same link as it always is, and we'll be sending out that reminder as well. But before we hop off, I know we only have a couple of minutes left. Does anyone have any questions for us or concerns or anything that they want to bring up? Okay, I want to make sure to thank Jordan. Sorry, I pronounced your agency's name wrong at the beginning. I was reading it as Care Partners. It just didn't come out that way.
Oh, no, you did. I was making a bad joke. It was saying because you were partners, highlight, and Care Partners. You nailed it. It was a bad joke, obviously. Didn't land. Sorry.
Oh, no, it's quite all right. It's been a long week for being a Wednesday. Anyway, we are super happy to have all of you guys here. Hopefully at the next meeting, we'll have more. Again, reach out if you guys have any questions, any concerns, and if you know of any partners that you think would make a good partner for us, please send them our way. And thank you all, and we will see you guys in October.
Thank you. Have a great day.
Okay, bye.
Bye.